So without further ado, I will present our first speaker. I'll let these ladies find themselves a seat. Professor Bhaskar Dasgupta, who is a consultant rheumatologist and a world expert in diseases such as polymyalgia rheumatica, giant cell arteritis, currently based at Southend University Hospital, and his focus today is going to be on GCA. So, if I can hand over to Bhaskar. Thank you.
Right. Thank you very much, B, for inviting me to the AGM of PMR-GCA Scotland. Really, it's a great pleasure for me to come back, and really, I can't remember how many years I've been working with Jean. The very first patient representative that I had the great privilege of working with when we tried to widen our interest in PMR-GCA. I'm not actually going to talk today about PMR at all, because I thought there are some aspects of GCA which are very important that I would like to highlight. But for the fact that all of you who have entered and come to this meeting, you have been handed a questionnaire. Now this is an extremely important questionnaire. We are developing what's called the EULAR, the European and the ACR, the American, so the EULAR ACR guidelines on polymyalgia rheumatica. And we can't do that without the feedback from our patients as to what outcomes, what measures you think are important for you. Now, we have to develop it according to certain methodological directives called grade methodology, which means that we have to survey the same questionnaire with our clinicians, our doctors, our nurses, scientists, as with our patients, so that everyone actually has a sight of all the possible outcomes that are reported in this condition. So I do apologize for the length of the questionnaire, but it's quite important that if you can, those of you who have PMR or GCA with PMR, if you could complete the questionnaire and leave it with me before you leave this meeting today. So, and please fill it according to your own perception. So it's not according to your charity, it's not according to your organization or your friends, it's your own perception of what are the things that are important. That's what we're trying to pick up. What's critical, what's important, what's less important in PMR. Thank you very much. So I'll get on with GCA. So I thought I'd talk to you about the current landscape, so sort of the history, so what's the past, what's the present, and what's the future of GCA and where we are going. So I'm going to talk to you about the history of GCA, and it's quite interesting that actually GCA was known for a long time. I mean, there are descriptions in history about GCA. And the promises and pitfalls of steroids. Sadly, in 2013, the only two conditions in the world, two medical conditions in the world that are treated only with steroids. One is PMR, one is GCA. Everything else has got something else that we treat it with. And that's the promises and pitfalls of GCA. Experience with other medications that we use in GCA. I'm going to talk to you about something very exciting that we have been doing in Southend, and I'm pleased to hear that many other parts of the world are trying this, the fast-track pathway. One of the most important things that's going to happen in the next 5 years, I mean, rheumatoid arthritis has had its day. The next 5 years of clinical trials and clinical research will belong to PMR and GCA. Take my word for it. Certainly the pharmaceutical industry and various products that are coming on stream, the first thing that they're considering, does it work for GCA, does it work for PMR? So this is the next 5 years are going to be the era of clinical trials for GCA and PMR to move treatment on from steroids. And what then might it look for GCA patients? So, an Arab physician about 1,000 years ago made the first description of GCA, someone who had headaches and who had visual disturbances. And of course, Jan van Eyck, and I'll show you the painting, really has preserved for you the first sort of medieval description of PMR and GCA in the terms of a beautiful painting of Canon van der Pele. And then there's the portrait of Francesco Gambetti by Piero di Cosimo, and I'll show it to you. Now, Canon van der Pele was a very important person, and if you read through his description, he had typical PMR. And this was, we are talking about in the 15th century, they didn't have steroids, and he suffered with severe muscle pain, severe stiffness, so he actually needed someone to move him from a place A to B, and he was a very important person. So this was recorded as a major disability related to PMR. And then, later on in life, 5-6 years, into this severe pain and stiffness, he then developed severe headaches, and you can actually see actually there's prominent temporal artery over here, and he had the classic description, De Kekker's paper, classic description of someone who had PMR with GCA. He actually died because of the severe muscle pains, and so without any treatment. So this is probably the first recorded description of GCA. Now, a doctor called Hutchinson in the 19th century described a man who had headaches and who had red streaks on his forehead. Horton was the first person from the Mayo Clinic. In 1932 described 2 cases, and in 1937 he then actually described the pathology, so he biopsied. He was the first person to arrange temporal artery biopsies, and in fact he showed inflammation of the temporal artery. That's where the term temporal arteritis comes from. Then people found that in these biopsies you had these cells which are called giant cells, and Gilmore described what's called giant cell arteritis. Sight loss in GCA is nearly 70 years old. So in 1938 there was the first description of sight loss in GCA, and we haven't made that much progress since. Then there was a description. All this is years ago. I mean, in Kilbourne and Wolfe in 1946 described it's not just the temporal arteries, many other arteries are affected in GCA, and they coined the term called cranial arteritis. The first treatment with steroids, that's the first report in 1958. So we are 60 years on from there, and 55 years on from there, and we still actually haven't got a better treatment. So that was the first report, and of course PMR and GCA was linked again over 50 years ago. So just shows you that really with PMR-GCA, what we have today is essentially what we had 60, 70 years ago. Why we need better treatment with steroids? Long-term steroids are the mainstay of treatment. However, most patients with GCA require long duration of treatment, at least 18 months. And I think that's an underestimate. A lot of people require it lifelong. It's got a relapsing disease course, as most of you would have found out, that it comes and goes, and you reduce the dose of steroids and you get the symptoms back. So these treatments work, but we still have lots of relapses. And of course, someone like me, I see a lot of people with steroid-resistant GCA. So it's not true that GCA always responds to steroids. And of course, almost everyone on steroids has side effects. And if you take in weight gain, it's 100%. But even serious side effects like fractures, diabetes, blood pressure problems, cataracts, glaucoma, but also the things that matter to people like mood changes, sleep disturbance, the change in the body appearance, the Cushingoid appearance. All these things, in fact, are prevalent in most patients with GCA. We know there is I do not wish to alarm people here, but you know, it's thought that GCA is a benign disease, that it actually doesn't shorten lifestyle. But in fact, it's not true, because if you get sight loss, the high doses of steroids, etc., and the cardiovascular effects are pretty impressive, and so it may have an impact on you know, the total lifespan as well. Certainly, there's a threefold increase of diabetes and fivefold increase in hip fractures in patients who are on steroids. So we need better treatment. I mean, it's not to alarm people, but we need better treatment than the standard of care. Sadly, the treatments that we have, you know, we use in rheumatology, don't work that well in GCA. And if you look at methotrexate, a lot of people are treated with methotrexate. It does work a little bit, but in fact, it's nowhere as good as we find in rheumatoid arthritis. And several trials have not found very good data, and some, a meta-analysis found that there's a little modest effect on reducing the dose of steroids. You still can't get away from the side effects of steroids. Drugs like azathioprine are used, and that trial was done in 1986. But you know, evidence-base-wise, we don't have medications that we can use much in GCA. The one drug that we have found somewhat useful of late is a medication called leflunomide, and we have published a case series on leflunomide. The sad thing about it is that it's so expensive to do a clinical trial after a drug has gone off license, and there's no pharmaceutical backup for a trial of leflunomide in GCA or PMR. So, and of course, all these expensive drugs that work in rheumatoid arthritis sadly have not been shown to be very effective in GCA. Whether it is infliximab, whether it's etanercept, rituximab, there's a trial ongoing with abatacept. There are some new biological agents which block IL-6, tocilizumab, and there's a trial that is going on, and that may have some promise in the terms of treatment of GCA. So, before we talk about the treatment, I'll talk to you about the fast-track pathway and what we have done and how patient groups have supported it. Certainly, we need fast-track. I mean, honestly, it is not acceptable that in this day and age, a medical emergency, a critical ischemic medical emergency like GCA is actually dealt with by a letter faxed to the secondary care specialist, and someone picks it up after a few weeks and sees the patient. Because we do see vision loss, and the vision loss percentage varies, but certainly whatever reports you look at, it's 15 to 25%. And the problem is that that's a calamity. So once someone loses vision because the artery at the back of the eye is blocked and the optic nerve dies, there is no going back. That's irreversible. So we've got to prevent it. And the only way you can prevent it is by having a fast-track system, very similar to what we have for stroke. So, and the fast-track system, the Act Fast system for stroke, has completely revolutionized the prognosis of stroke. And we need a similar problem, a similar pathway for GCA. And look at this. I mean, this is the data that we published many, many years ago, 3 years ago. And that's the time it takes from symptom onset to diagnosis, 35 days. 35 days, and this is pretty standard for GCA. And it's not just the GP, it's the patient awareness. So sometimes GCA symptoms are very non-specific, so there may be delay in getting to the doctor. The symptoms themselves may defy diagnosis, and there might be training problems with the GP or even the secondary care specialist. Many of our patients go blind while having endoscopies with the gastroenterologist or waiting for the MaxFax people to look at their jaw pain. So, but that is still the prevalent norm of diagnosis. And the problem that we are highlighting is that it's not just headaches that means GCA. And GCA can occur without headaches. 20% of GCA patients actually have GCA without headaches. Sadly, it's this group of patients we frequently see loss of vision, where telltale headaches delay the diagnosis of GCA. And you know, this lady actually had constitutional symptoms. She lost weight, she had fever, night sweats for 6 months, polymyalgia for 3 months. The diagnosis was made only when she lost vision in her right eye. And you can see the ischemia, she had jaw pain, and her tongue actually necrosed. Sadly, the prognosis and outcome wasn't very good. And the point I make is that people who lose vision, it becomes a disease with a high mortality. And we need to prevent that. So we need to re-examine all the patients who lose vision and actually what happens to them. And it's not a benign disease at all. And sometimes patients lose vision in both eyes. That's about 30 to 35% of the people who have sight loss. This can all be prevented. And the outcomes of sight loss, of course, they have loss of independence, loss of confidence, depression becomes a major factor for these patients, and to almost suicidal depression, loss of mobility, residential care, and certainly it has a major impact on the family, the spouse, the children, to look after them. And then they suffer medical complications such as hip fractures, infections, and there's a huge impact on the family. This is what we are trying to look at, and we are very pleased that the NHS Commissioning Board is actually very interested in looking at what happens to patients when they have sight loss, and looking at both the personal and the psychological and the financial consequences. So in Southend, what we have is we have a rapid access GCA clinic, and we initially refer with suspicion of GCA, they contact the department straight away. We have a GCA doctor on call throughout the week, and we see them within a 1 working day. Of course, all our patients, before they get seen, if you have suspected GCA, they get put on steroids. It doesn't matter. Even if you don't have GCA, if for 3 weeks you have high-dose steroids, it doesn't matter. If it's a little price to pay to avoid vision loss. And if they have ischemic signs and symptoms, if they have jaw pain, they get referred to our A&E, they get intravenous steroids. And they get temporal artery biopsy, they get temporal artery ultrasound, and certainly some of our patients, of course, do not have GCA. They may have other serious complaints related to the headaches, or they may have other conditions that might mimic GCA. And of course, those are the ones that we pick up after that. But essentially, anyone with suspected GCA, if there's no contraindication to steroids, get started in steroids, and we see them within 24, 48 hours. So that's the fast-track system, and we are very pleased to know that it's had a huge, if you look at sight loss, huge change in sight loss. So we can actually almost take it out. We haven't been able to take it to 0, and the reason for that is that we still have a delay from symptom onset to making the diagnosis. We don't know what's the problem. And it may be that there's a delay in patients actually recognizing their symptoms, that they should be like these symptoms, like flu-like symptoms, night sweats, or aching, or a lot of people feel that these are fine. Even jaw pain, sometimes people don't click that this might be a feature of these other conditions. So, but suffice it to say, we have enough evidence that this fast-track system works, and it really reduces sight loss. And there's a huge cost of blindness, and this is what we are looking at with the NHS Commissioning Board, and in the next few months we should have proper data, literally pounds saved by this fast-track pathway. And this is work in progress. And essentially what we are saying, that this is of course not Scotland data, but unless the fast-track pathway costs more than £202,000, it is cost effective. It saves so much money. And if you look at the average number of life years for someone aged 74, that's the average age where we see GCA. I know we see GCA in younger patients as well. The quality of life lost, new cases of GCA in England per year. And if you really put that all in a formula, the fast-track system is very cost-effective in terms of just even the financial aspect. And of course, patient groups have been really the core to all this, and all this wouldn't have occurred really because we've had so much support from PMR-GCA UK, from Northeast, from PMR-GCA Scotland. Of course, Jean was the first person I started working with. How many years ago, Jean, was that?
Or was it not? It was 2006 I came down.
Yeah.
No, 2007. But we've been working with Jennifer before that.
Yeah. True, true. Thank you very much. And Jennifer has been, Jennifer was in our PMR and GCA guidelines as well.
No, sorry, 2008.
And so none of this is possible without patient support groups. And one thing that really is bothering me, that we still haven't got down shortened the time from onset of diagnosis to seeing the patient, the GP, because there still seems to be a big gap. And patients, that's where groups like PMR-GCA Scotland can do so much to raise awareness of the condition. So, in terms of what are the other new things that we are doing, we certainly are doing temporal artery ultrasound, and that's really very, very useful in getting non-invasive diagnosis. You see what's called a halo, and I'll show you. These are the blood vessels that are involved mainly in GCA. This is the temporal artery, and that's the parietal and the frontal branch, and they get inflamed. That's why you get the scalp pain and the headache. And what we do is essentially put a ultrasound probe, look at the various artery and its branches, and these are the abnormalities we get in people with GCA. You can see the blood flow going through, and this is the black area, that's the halo. That's the halo around the artery of an inflamed blood vessel. And let me see whether this works. So that's a clip from someone, so you can see the blood vessel is really constricted, and so there's tiny amount of blood flowing through, rest of it is all occupied by, and you can look at other arteries as well, the axillary artery, like that. And one of the things that we realized, that GCA is not just confined to the temporal artery. When you do ultrasound, you actually find it in the axillary arteries frequently. And that may explain why 5-10 years down the line, patients with GCA develop aneurysms of the various arteries. So we are looking at the TABL study, ultrasound versus biopsy, and there are other forms of imaging in GCA. Anyone in this room has had a PET scan for GCA? Right. So, thank you. So, this is the sort of abnormality that we're looking for in patients, not just with GCA, but also in PMR. So, we are finding increasingly large vessel GCA in people with PMR not responding well to steroids. And this is one such patient, and you can see that these arteries, these are the subclavian and the axillary arteries, and they really become very inflamed in these patients. And sometimes you get inflammation in the aorta, fall down the aorta, and these branches of the aorta called the iliacs. And you can treat this. These patients don't respond to the standard treatment. There's a patient who responded very well. We have written up to tocilizumab. You can see the dramatic change in the PET scan before and after the treatment. Similarly, you can get we do other imaging called the CT angiograms to look, and this is again a patient with PMR who had severe residual pain and stiffness, and she had quite severe narrowing of the blood vessels. And again, you can treat that very effectively with other drugs. So one of the things that we would like is that patient groups should they should insist that the standard of care must be a temporal artery biopsy. So we shouldn't be treating patients with suspected GCA without temporal artery biopsy. So it is the gold standard, provides prognostic information, should be done in every case. It really should be done within 1 week, and all rheumatology units should have a link with a surgical unit that does these biopsies. And that's very important. And you know, biopsies give us so much more information. Can you see that this artery has been reduced to a pinhole by this inflammation? And that's why you get sight loss. So we can then look at what are the other therapies that can reduce this proliferation of the artery that blocks the artery. So these are the challenges we have. What outcomes are critical and important to patients? And that's why we've circulated that questionnaire to you. Now, that question is about PMR. Another one in the pipeline is a similar questionnaire on GCA, so which I will circulate to you shortly, which probably includes all those questions as plus some additional questions on GCA, such as the aortic aneurysms, etc. We really have a challenge to find better therapies. We really do. And society has a challenge. It has to find the resource, like it did with rheumatoid arthritis, like it did with ankylosing spondylitis, like it did with psoriatic arthritis. So the society will then have the challenge finding the extra resource to fund that. And one of the important things we are trying to do is to actually, even doctors have a rather distorted view of what GCA is. We're trying to change that. So we have to do that internationally, like addressing the ACR 1990 classification criteria. What we need to do, you see, doctors tend to be very obsessed with clinical measurements. What we really need to do is to bring in disease scoring instruments that includes patient-reported outcomes, such as, that's why that questionnaire is so important, and disability measures. So the best way to assess whether an outcome, a treatment is working, is whether it changes patient-reported outcomes and disability. So, I mean, those are the challenges ahead. Really another important challenge, and I can see lots of enthusiastic people in this audience, we need to change standards of care. Really, we need to change standards of care. We need to really highlight what the burden of disease is. You see, NICE will look at the guidance. I think it's getting closer and closer to looking at GCA guidance. That's the news that I get. And certainly the noise that we have all made together, I think it's reaching these deaf eardrums. And the factors that will really enable NICE is that if we can stress the preventable disability that GCA causes, the sight loss, the steroid side effects, the large vessel involvement, you know, you get this aortitis and aneurysms, versus effective therapy. So NICE will only be motivated if there's an alternative to steroids as well. So, but then it will also have to look at the resource impact. So expensive treatments for rheumatoid have changed rheumatoid outcomes. It has had a resource impact. And I suspect that's going to be coming with GCA and PMR as well. And I think we need to emphasize that there's variation in practice. And I have no qualms in saying that all patients with GCA must be referred to secondary care for a specialist opinion and further investigation. Thank you very much.
Thank you, Bas.